So firstly, I'd like to begin by acknowledging the traditional custodians of the land and pay my respect to the elders past and present, and extend that respect to Aboriginal and Torres Strait Islander people here today. So we'll start with Adam. So Adam is has got a combined position, academic position with the University of Adelaide and a clinical position at the Royal Adelaide Hospital. He is a neurosurgeon. His position with the university as the Abby Simpson Clinical Fellow, and he is undertaking a body of work to do with research into traumatic brain injury. He and Mark have both had some overseas experience, including both having worked at Cambridge at some time together in the past. So I'll hand over to Adam.
Thanks, Marianne. Thank you very much for the introduction, and thanks everyone for your time today. I will be disappearing, I think, before the end of Mark's talk. I'm sorry, Mark. I just got a patient on the table. We had a COVID patient, a broken heel patient who's taken a long time to get to sleep. We've only just started. Can you see my slides okay?
Yeah, we can.
Okay, thank you. And so I'm going to try and keep it as brief as possible. I thought I had 10 minutes, then I heard it's only probably 8, and I've got much more than that to talk about, so I have to talk a little bit fast. But I'm talking about individualized therapy for acute brain injury, and this is a bit of a pet topic of mine, particularly for traumatic brain injury. That's the area of expertise of my my clinical background and what I did my fellowship in with at Cambridge with Peter Hutchinson and the Adam Brooks Hospital. So full disclosure, I am supported by the Neurosurgical Research Foundation, and they do fund my research assistance. Traumatic brain injury is a very big problem, and also for a very young population as well. Almost 100 people per 100,000 Australians are affected every year, with estimated costs of $8 billion annually. And we see about 180 moderate to severe TBI patients per year. That's one every second day on average. Head injury is a complex thing. It's a complex injury in a complex organ. It's a great slide. Lola, if you're online, thank you very much for this slide. So there's obviously primary injury, then we have secondary injuries that develop. They develop over time. They're dynamic, not static. They're associated with swelling, ischemia, hypoxia. Another pet topic of mine is turgor, or elasticity and compliance, that Peter Riley introduced me to that concept many years ago. And you know, every brain injury is not the same. So it's an umbrella term. It's a bit like chest pain. It's an umbrella term. It could mean PE, it could mean MI, it could mean many things. So TBI is very different. So you have a broad spectrum of pathology, from diffuse axonal injury and swelling to acute subdural hematomas, traumatic subarachnoids, intraparenchymal hemorrhages, extradural hematomas, and combinations, of course, of all the above. And therefore, interventions are very different. Standard therapy for as long as I've been practicing has been at least the intracranial pressure monitor, common monitor, top left. Then we're looking more towards dual lumen catheters and multimodality, sometimes 4 lumen, measuring brain tissue oxygen, microdialysis sensors as well. Intracranial pressure monitors combined. Some people get a craniotomy, some do not. Some people get a ventricular drain, some don't, and some people are just observed. And again, combinations of the above, and escalation of therapy is appropriate. So who gets what really depends a lot on where you are. So in Adam Brooks, where Mark and I both worked, we had some world-leading neurotrauma experts, Peter Hutchinson, Marek Kuznicka, Peter Smielewski, David Menon, all worked at the neurocritical care service in Adam Brooks Hospital. And you know, these are world-leading experts in traumatic brain injury. And of course, the sort of things that they'll provide will be on the cutting edge, versus the Royal Adelaide, where we are just now. Again, for a long time, it's been based on the Brain Trauma Foundation guidelines of management of traumatic brain injury, predominantly with intracranial pressure monitors. For a recent period, we dabbled with brain tissue oxygen combined monitors with the rheumatic devices. We've gone back to the common devices now. And at the end of the talk, we'll be talking about BONANZA. So this is the brand new brain tissue oxygen monitoring study that we're fortunate to be a part of as well. So again, what you get depends on where you are. Monitoring has been the backbone of head injury management for a long time now, and it's still relevant. It started very, very basic. And I'll go through a few slides just now of how it's evolved into more individualized therapies. In addition to that, of course, I mentioned brain tissue oxygen monitoring, microanalysis, which I'm not going to talk about much today, probably mostly because I don't understand it. And then there's higher functions like pressure reactivity index, optimized CPP, and other things like that as well. So ICP is a very well recognized relationship between intracranial volume and pressure. This is something we've known for many, many years. If we look at a next level, if you look simply just at intracranial pressure as alive or dead, you can see how ICP can be fairly consistent, whether the good outcome or bad outcome versus death is quite distinct. So there's clearly something more than just ICP controlled in managing these head injury patients. Cerebral blood flow is very well regulated for different cerebral perfusion pressures. Again, it's a well recognized phenomenon, so this is not new. But if we look further at other measures of CPP, we can see how complex it can become when you're starting to look at the cerebrovascular microcirculation. We flip this around a bit. This is the concept of RAP. And RAP is its relationship between intracranial pressure and pulse amplitude, and it demonstrates how compensatory the brain is for pending disaster, with an RAP of 0 being in that good compensatory reserve. As it rises more to a +1 relationship, we're heading towards pending doom. And then finally, as RAP gets less than 0, this is a brain that is completely decompensated, and there's no more relationship between amplitude and ICP. If we now look at the relationship of systole and diastole in blood pressure and intracranial pressure, we can look at something called pressure reactivity index. It's a Pearson correlation coefficient. Really, it's a measure of cerebral autoregulation, but when I made these diagrams in the past, we were actually looking at the relationship of, again, cerebral reactivity and the brain compliance to a raised ICP phenomenon. And what you're going to be getting, if you plot this, you get a hysteresis loop, and the shape of the loop is a bit like the Pearson correlation coefficient, and the slope of the loop that you can determine can talk about not only cerebral autoregulation but also the brain compliance. Cambridge group look at that and look at it in different states of normal and abnormal. And you can see on the bottom part of each graph how the correlation coefficient is slightly negative or very positive, depending on whether the brain is compensating or not. Finally, RAP does change a lot, again, in terms of brain compensating or not. If this instance here, you see a patient who's compensating relatively well for ICPs in what we consider a normal range of up to about 20 millimeters of mercury. But then as the RAP starts to slide down into negative numbers, you can see how the ICP on the top of the screen really just taper off as the CPP decline. So these are really individualized measures now of what's actually happening in the patient's brain that are much more beyond what we traditionally measured for ICP. This is the concept of optimized cerebral perfusion pressure. And it's really a combination of plotting the pressure reactivity index against CPP, and you get this U-shaped curve for CPP, which is the second figure from top. And that theoretically should be an optimal CPP that you could target for that patient under given circumstances. Again, remember, this is dynamic, it's changing all the time. So this could be potentially an individualized therapy. If you target CPP individualized for that patient, you may be able to get better outcomes. So individualization therapy, again, it's a topic that I like the concept of. I think the current guidelines certainly are too dogmatic. There's no way we can say that an ICP of less than 22 and a CPP of more than 60 is one size fits all. So if we can use things like PRX, RAP, and CPP opt, we can maybe individualize therapy more to that patient's individual circumstance, and again, between time points for that patient's ICU stay. We can also look at things like ICP pressure time dose, and I'll show a diagram of that in a second. We can look at other markers of cerebral compliance, like I showed before, the systolic-diastolic relationship of ABP versus ICP. Then we can look at other things like boosted BONANZA, looking at brain tissue oxygen concentration, again, optimizing that for the individual patients. And that's actually what I like to focus on now, is looking at brain tissue oxygen. So these are current tools we're using. That Chapman ICP Express box is very familiar to many of you. It hasn't changed in probably 30 years. We're now looking at some newer Chapman box devices which can look at ICP dose. And that middle top diagram shows for an individual patient, you can measure how long has a patient spent above a certain ICP, and measure ICP dose and outcome. Top right is the brain tissue oxygen monitor that we're using now, showing there a brain tissue oxygen of 33 millimeters of mercury for a temperature of 37 degrees. Bottom left is the lovely ICM Plus software that you can measure PRX, RAP, CPP opt, and other individualized measures, again, which takes some getting used to, but we have access to the software now. Finally, I want to talk about brain tissue oxygen. I really start off with a boost trial. So I'm really talking fast, a lot to get through, so we're almost at the end. But the boost 2 was a phase 2 randomized controlled trial published 4 years ago today, looking at if we had ICP directed therapy alone versus ICP and brain tissue oxygen directed therapy, are we going to get better outcomes? And that makes sense. If you can optimize ICP, there's certainly evidence for that. What about optimizing cerebral oxygen and avoiding hypoxia in particular? Should those patients do better? And they probably should. So there are 4 effectively tiers, type A through type D. What the study really was designed to do was to develop the protocol. It did show improved mortality and better outcomes for combined therapy versus ICP alone. But again, it wasn't powered for that. So they've gone on to show that you can show the better outcomes. But they've gone on to do a boost 3, which is a phase 3 clinical trial, which is underway now. 2-arm single-blind prospective randomized controlled trial. They're looking for over 1,000 patients, and the primary outcome being extended Glasgow outcome at 6 months, with the secondary measures as identified just there. Which brings us to the local study, which is BONANZA. It's the brain oxygen for Australia New Zealand outcomes assessments. Andrew Udy and Shirley Valance in Melbourne. It's ANZIC supported, NHMRC and MRFF funded, and also industry supported by Integra. Again, it's very similar to BOOST 3. It's a multi-centre blinded prospective randomised controlled trial looking at severe TBI. We're comparing ICP alone versus ICP and brain tissue oxygen management according to tiered therapy strategy. Looking at just under 1,000 patients for BONANZA. We recruited our first on last Thursday, so we've got fortunately got some pictures to show, which is very timely. Again, outcomes are very similar: 6-month Glasgow outcome extended, and all-cause mortality as secondary measures. So last Thursday, we had a 65-year-old man who was retrieved from Boolaroo Hospital. He had a GCS 11 after a fall from a 3-metre height. 2 hours later, he was GCS 8. He was intubated. He was retrieved. On arrival, he had this scan, which showed quite a large left intracerebral temporal hematoma with a right convexity acute subdural hematoma. It was not a surgically evacuable lesion, but he needed an ICP monitor, so we managed to recruit him. We took him to theatre. On the right of the screen, you can see after, I didn't get any photos during because I was scrubbed, but after insertion, you can see how this thing sticks out the head much more. It's not even, and there's a 2-lumen system, so we're measuring intracranial pressure and brain tissue oxygen. And when he went back into ICU, you can now see that he's hooked up to that Lycox box. You can see that the brain tissue oxygen is only 6. That was okay. It did come up afterwards. It takes some time to normalise. Post-operative scans, you can see how the bolt's sticking in that right frontal region. And I grabbed a couple of slices there, just demonstrating how the 2-lumen, you can just see there are 2 dots in the bone window CT on the far right. The brain tissue oxygen, the other representing the Cochrane ICP bolt, and they're both sitting in relatively normal right frontal parenchyma. So first BONANZA recruits, we couldn't have done it without Steph O'Connor in ICU and Ben Reddy in ICU, and of course Lola is our NRF funded research assistant. So many thanks to the 3 of you, the Melbourne guys who are hugely supporting in that, and looking forward to doing some more individualised care for our TBI patients from now. Thanks very much.
Thank you very much, Adam. We've pretty much run out of time. You did very well.
Sorry.
And if people could write any questions, maybe for Mark in the chat. I guess maybe just one comment or question, because you did allude at the start to the fact that TBI patients in Cambridge would get a different care, or I suppose different care is what you're suggesting from what they would get at the Royal Adelaide. But I'm guessing that a lot of the things they would do differently there are maybe as yet unproven in terms of improved outcomes, both in terms of mortality and functional outcome. So is that what you're suggesting, or are there really things that we're not doing here that should be done?
I can't say that the outcomes overall, the time I spent there, Mark might be able to suggest differently. The outcomes, I think, were any different. So I think, we do things well, they do things well, we do things well. So can you still hear me okay? My skin frozen, yeah. But look, they measure more things because they can. To be honest, it's not proven just yet. It needs to be, and I think it will be. It's common sense, but it's one of those things that we must show evidence for. Is treating brain tissue erosion going to cause any harm to the patient potentially with some of the algorithms that we need to do to increase brain tissue oxygen? I suppose the other point to make is that you're right. This is it's almost a little bit backyard stuff, and it's that British engineering in the back of the shed stuff. So Peter Hutchinson's triple bolt, for instance, they were big ungainly circles of things, and they really were manufactured in someone's backyard. So they made them in the backyard, they sterilized them. It's never approved by anything at all. It's always a little bit loose there. Mark might have a different interpretation, but I found it a little bit loose. Is that we're going to try it, we're going to do it, and they're certainly published widely, and it's very well scientific based. But at the moment, a lot of what they're doing is not evidence based.
Exactly. Yeah, and I guess there are challenges in terms of what outcomes you measure and variability of patient population.
Yeah. Such a varied injury spectrum. Yeah. Is GOSC enough? Yeah. Okay. So thank you very much.
In the interest of time, so thank you very much, Adam. We'll let you get back to your surgery. I'm introducing Dr. Mark Plummer. So Mark is our newly appointed head of research in the ICU at the Royal Adelaide Hospital. He originally trained in Adelaide, but he went off and did a postdoc in Cambridge at Addenbrooke's, same time as Adam, and also did a clinical fellowship in London, and then was working in Melbourne for a few years before he recently joined us. So one of his prime interests is also neurosurgical research as it pertains to ICU care, and he's going to tell us about a study that he is planning to set up at the Royal Adelaide Hospital. Thank you, Mark.
Thanks very much for that introduction, Marianne, and thank you everyone for attending today. So what I'm really presenting here is an idea that I want to roll out at the Royal Adelaide Hospital over the next 12 to 24 months. And it's looking at the therapeutic potential of very high doses of intravenous vitamin C for the prevention of vasospasm in subarachnoid hemorrhage. Subarachnoid hemorrhage is a form of stroke. It affects 2,500 Australians a year, or 600,000 people worldwide, and it has very high rates of death and disability. And one of the primary determinants of poor outcome following subarachnoid hemorrhage is those patients who develop vasospasm. Vasospasm is a condition whereby the blood vessels traversing the clot in the hemorrhage undergo spasm, which causes a decrease in blood flow to distal brain tissue, which ultimately results in stroke. And the prevalence or incidence of that is actually quite high. So about 2/3 of patients will develop vasospasm. About half of those will be detected clinically at the bedside, and half of those again will have a permanent stroke as a result of that. And really, we are quite limited in our treatment options to date. So in the last 30 years, there's really only been one non-interventional pharmacological therapy approved for the treatment of vasospasm, and that's nimodipine. And it may be that very high doses of vitamin C could offer some therapeutic benefit. So vitamin C is an essential micronutrient. Its role is as an antioxidant in the body, and it's super concentrated in the brain. So the concentration of vitamin C in the cerebral spinal fluid, which bathes the brain, is 4 times higher than that in the blood. And within the brain cells itself, it's 80 times higher than the plasma. And so that's driven by active transport. And the reason is because the brain's a very metabolically active organ, and it's lipid rich and fat rich. And so that metabolism generates lipid peroxidation, which generates oxygen-free radicals, which damage the cell tissues. And so you need very high concentrations of this essential micronutrient to nullify the effects of those oxygen-free radicals. What has been nicely shown is that after traumatic brain injuries, the level of vitamin C, both in the CSF and the plasma, plummet to very low levels. And in fact, the nadir in the plasma vitamin C concentration correlates with worse clinical outcomes. These are preliminary data for a trial that's currently underway at the Royal Melbourne Hospital, which I set up prior to leaving, and it's looking at the concentration of vitamin C in the plasma and CSF of patients with subarachnoid hemorrhage. So these are data from 10 patients out of a total of 20 that we're hoping to collect. So again, preliminary data, I don't want to make too many early assumptions. But what you can see here on the y-axis is the vitamin C concentration you can see in the plasma and the CSF. The red lines indicate the lower limit of the healthy range. So what we've seen is that in the plasma, the levels are certainly below normal, but in the CSF, in these patients who've had a subarachnoid hemorrhage, the levels of vitamin C are dramatically lower than what's seen in health, and in some patients almost fall to zero. We're collecting these samples in patients who have an extraventricular drain or an EVD placed for clinical needs, so usually for hydrocephalus, which allows us to sample CSF from the brain at regular intervals. And certainly the trend of what we're seeing is that the levels decline over time. And in those patients who develop vasospasm, there's a significant difference at this stage between those patients who develop that terrible complication of vasospasm compared to those patients who don't have that abnormal tightening of their brain arteries. So in terms of preclinical data, there's some fairly convincing preclinical data that high doses of vitamin C may have therapeutic potential. This is a horrendous slide. It's table 1 of a systematic review that I published last year. And really the take-home messages are that in preclinical studies, vitamin C has predominantly been given by the parenteral route. And it's been given in very high doses. So doses up to sort of 500 milligrams per kilogram per day or higher. And when given parenterally at very high doses in models of ischemic stroke, subarachnoid hemorrhage, and traumatic brain injury, parenteral vitamin C appears to have a benefit in decreasing infarct size, decreasing vasospasm, and improving functional outcomes. The human data to date, again from the same systematic review, is far less convincing. Vitamin C has predominantly been given by the oral route, and the doses that have been given have been very low. So 500 milligrams to 1,000 milligrams per day, compared to, in the animal studies, 500 milligrams to 1,000 milligrams per kilogram per day. And what we know is that the enteral route is really inadequate in these patients. So the gut can only absorb 200 milligrams of vitamin C a day. So giving 500 milligrams or more, it simply gets excreted rather than being absorbed. So these human studies in stroke and traumatic brain injury have failed to show any benefit of vitamin C, which I suppose isn't surprising considering the study design. And really the interesting study here was a Japanese observational study from over 20 years ago, where they reported the outcomes on 217 patients who had an intracisternal catheter inserted as part of their routine clinical care. So at the end of clipping an aneurysm that had ruptured, the surgeons would place a catheter and infuse a solution of vitamin C and urokinase into the subarachnoid space for nearly 3 weeks. And this fairly large study reported vasospasm rates which were dramatically lower than what was seen at the time. So 3% incidence of vasospasm compared to 30%, which was reported in Japan at the time, and very low mortality rates. Now, this treatment has never been interrogated in a randomized controlled trial. There are no centres worldwide who are routinely putting in intracisternal catheters at the end of clipping. However, there is an effective way with far less risk of increasing the vitamin C in the brain, and that's giving it in very high doses intravenously. So in terms of the pharmacokinetics of why we would give very high doses of vitamin C, we know from the general ICU literature that the majority of our patients in the ICU develop hypovitaminosis C, and that quite high doses are required just to return these patients to normal physiological levels. So 2 grams intravenously twice a day for 2 days are required to return patients to the normal range. So if you compare that to the 500 milligrams that have been given orally a day to the majority of the clinical studies so far, it's very clear to see that the trials to date have been inadequate to assess an effect of vitamin C if it were there. So the question is, how much is enough? And I suppose we don't know. And the next question to ask is it safe to give very high doses? And so these are the results of another systematic review that we published last year, looking at harm associated with mega doses of vitamin C, which we defined as those patients receiving more than 6 grams per day. There's actually been quite a number of studies, so 9 randomised controlled trials, including over 2,000 patients. And what our review exposed was that doses up to 200 grams a day are very well tolerated. So that's a huge dose and is well tolerated. And there's no evidence that megadose vitamin C is more harmful than placebo. And so when I was working at the Royal Melbourne, we, in collaboration with the Florey, established a large mammal study looking at megadose vitamin C in septic shock and had a signal of benefit, and have now rolled out a clinical trial looking at megadose vitamin C in septic shock. So we have experience with this therapy. This is an open label multi-centre trial where we're randomising patients, and in the highest arm they're getting a 30-gram load and then 60 grams intravenously twice a day for 2 days. I've established a relationship with Biological Therapies. This is a Melbourne-based company that are able to produce clinical grade sodium ascorbate at a dose presented as 30 grams and 100 mils. Of note, sodium ascorbate is very salty, so it's an equivalent sodium load of 3% saline, which may have benefits for our neurosurgical population independent of the antioxidant effect. So what I'm proposing to collaborate with the Royal Adelaide on is a series of trials of megadose vitamin C for subarachnoid hemorrhage. The observational study is underway at the Royal Melbourne and should finish recruiting hopefully this year, depending on how the COVID surge settles down. And then I want to establish a pilot study, then ultimately a multi-centre phase 2 randomised controlled trial, which I'll look to seek ANZIC's clinical trials group endorsement. The pilot trial, which is the protocol I'm currently working on, will be a multi-centre parallel group placebo-controlled blinded trial, and ultimately trying to recruit 30 patients with subarachnoid hemorrhage within the first 3 days of their admission, and randomising them in a one-to-one fashion to a usual care arm, and then two doses of intravenous vitamin C, so 15 grams a day for 21 days, which is the period at which they're at risk of vasospasm, or 30 grams a day for that same time period. Primary outcome will be protocol adherence and enrolment rate and tolerability, with secondary outcomes looking at pharmacokinetic modelling for vitamin C, both in plasma and CSF, neuroinflammatory markers. We're looking to set up a transcranial Doppler protocol here at the Royal Adelaide ICU, and then clinically looking at delayed ischemic neurological deficits. So a sort of a whirlwind of something I'm hoping to establish here at the Royal Adelaide in the next 12 to 24 months. And hopefully the protocol will be completed by the end of the year.
Thanks very much, Mark. Now there is one question from the audience, so that's John Beltrami, who's asking if there are known risk factors or predictors for vasospasm occurring, complicating subarachnoid hemorrhage. I guess he's inquiring whether there would be a more focused patient population for a clinical study.
So thanks for the question, John. And there is the primary predictor of vasospasm is the blood load in the head. And so there's actually a CT grade called the Fisher grade, which is used to predict your risk of vasospasm. And that's the grading system is essentially the volume of blood. Predominantly what we see in our ICU patients is if you're sick enough to end up in ICU with a subarachnoid hemorrhage, you usually have the higher grades of subarachnoid hemorrhage. And yeah, so that's the primary predictor is the blood load.
You're doing your feasibility currently mainly through Melbourne, and then you're going to do a phase 2 based in Adelaide with a number of sites. What's going to be the clinical outcomes or the outcomes that you're going to look at for that particular study?
So for the phase 2 study, will be based on similar study designs of the failed trials, of which there are many in subarachnoid hemorrhage. So trials of statins, trials of magnesium, trials of antifungals have all failed to show any benefit, but routinely they have used delayed ischemic neurological deficits, which is a clinical diagnosis, to power their studies and as a primary outcome. And I suppose that it is a patient-centered outcome. And it's one of the difficulties of studying subarachnoid hemorrhage is that there is a difficulty in hard outcomes.
Yeah, because that's a difficult outcome to quantify, isn't it? And
it is.
Same problem as with Adam's proposed TBI work, although maybe not so much. It's highly variable.
Yeah, so we will power our study to that, but then have it collect a variety of plasma and CSF markers as well as radiological evidence with transcranial Doppler and CT perfusion as secondary outcomes. But I think we'll power the study as they did in the STASH trial and the MASH trial to delayed ischemic neurological deficits, which should, in those trials, the sample size was between 1 and 200. And so I think if we were to get ANZIC CTG endorsement, that across Australia, if we could get 4 or 5 sites, that recruitment should take between 12 and 18 months. Yeah,
that's right. Okay, well, I want to thank both our speakers. That was a very interesting session, basically on neurosurgical type research that we're doing at the RAP. So thank you very much.